Let's start with a warm-up review. First question, what histological findings of the distal duodenum are most likely seen in a patient with celiac sprue? We're going to see blunting of the villi and hyperplastic crypts, and there will usually be lymphocytes in the lamina propria. Next, what arterial branches come off of the celiac trunk? The three branches that directly come off the celiac trunk are the left gastric artery, the splenic artery, and the common hepatic artery. And then the common hepatic artery gives off the gastroduodenal artery, the right gastric artery, and the proper hepatic artery, which then divides into the right hepatic artery and the left hepatic artery. Next, a woman with a history of hypertension presents with a sudden onset of sharp, tearing chest pain that radiates to the back. What's the most likely diagnosis, and what would be seen on a chest x-ray? Well, this is a classic description of an aortic dissection. And the classic chest x-ray finding would be widening of the mediastinum. Now let's get started with the lecture.
Welcome back. We're going to continue talking about evidence-based medicine and how we apply the results of our studies and testing in a practical way. I'm going to assume that you are watching these videos in order and that you've already seen the lectures on research study design and evaluation of diagnostic tests, because this lecture is going to build upon those concepts that I covered there. One thing we touched on briefly in that video was the concept of disease prevalence and disease incidence. But let's define these terms a little more precisely. This is pretty easy to understand, and it's also very high yield for your test. Let's start with prevalence, since we were just talking about how prevalence changes the positive and negative predictive value of a test. What is prevalence? Prevalence is calculated by putting the total number of people in the population that have a certain disease in the numerator and putting the total population in the denominator. This gives you the proportion of the population with a certain disease at a given point in time. This is point prevalence. Say we're looking at the prevalence of COPD. We don't really care if the person has newly diagnosed COPD or if they've had the disease for 15 years. All we care about is how many people in that population have COPD, period. That's not true for incidence. Incidence only concerns itself with new cases in the population. So to calculate incidence, you take the total number of new cases diagnosed over a given period of time and you divide it by the total number of people at risk for the illness during that period of time. So incidence is concerned with new cases and prevalence is concerned with total ongoing cases, whether they're new or old. With this in mind, you can see that some diseases will have a greater incidence than prevalence, and some will have a greater prevalence than incidence. Take COPD, for example. Only a few people are diagnosed with COPD on any given day, but when they are diagnosed, that diagnosis stays with them for the rest of their life. So the incidence may be low, but because it's a chronic disease, the cases just continue to build up. And this yields a high prevalence. What about an acute gastroenteritis, though? Think about like a 24-hour stomach bug. That may only last a day or so, but it can occur several times a year, unfortunately. So at any given point in time, there will be a lot of people with gastroenteritis, which means there is a high prevalence, but also because it may happen more than once a year, you can also see how the incidence or new cases during a given period of time could be really high too. So one way to think about this relationship is that prevalence roughly equals the incidence multiplied by disease duration. And because with chronic diseases, the disease course is very long, the prevalence of chronic diseases is greater than the incidence. For acute diseases like the common cold or a stomach bug, the prevalence will roughly equal the incidence. One important thing to remember is that incidence is the number of cases over a given period of time divided by the total population at risk. So when you're talking about COPD or some other disease, the population who already has the disease may not be a new case, so they're not counted in the denominator, but neither are they at risk anymore because they already have the disease. So remember to correctly determine the population at risk when you're calculating incidence. You need to really understand incidence and prevalence, and this is a pretty basic concept and it's high yield, so just make sure you understand that difference. Next, let's talk about odds ratio and relative risk, which is a 5-star topic. You're going to see questions about this. Both of these are used to evaluate results we get from our study. So let's start with relative risk. Remember that relative risk is calculated from cohort studies, which is where you're confirming risk factors. Relative risk is the probability of getting a disease in the exposed group compared to the probability of getting that disease in the unexposed group. Now, let's build another 2x2 table, just like we did for sensitivity and specificity. This is labeled slightly differently. We still have disease written on the x-axis, But for the y-axis, instead of looking at a test result, we're looking at some exposure, some risk factor. This table will help you determine the relationship between the risk factor and the disease outcome. Again, this is a great marker board topic. This is definitely high yield for step 1, so it's important to understand these concepts and know the equations to calculate odds ratio and relative risk. So what's the equation for relative risk? It's A divided by A plus B all over C divided by C plus D. You're going horizontally here. So these equations are fundamental components of some other calculations as well. If you know A over A plus B and C over C plus D, we're going to use that as part of the equations for attributable risk and for odds ratio. We said that odds ratio is used for case control studies, which are often used to identify risk factors. The equation for odds ratio is A over B divided by C over D. So the odds ratios compare the odds that someone will develop the disease in the exposed group to the odds that someone will develop the disease in the unexposed group. A over B divided by C over D. Now, you may see this equation written a little differently in some review books where it's written A over C divided by B over D. But don't get confused. Both of those equations are correct. They are actually equivalent, although it might not be immediately obvious. A over B divided by C over D equals A over C divided by B over D. Just try plugging in some numbers or work through the algebra yourself and prove to yourself that those are equal. But here's another important thing to know. The odds ratio approximates the relative risk if the disease prevalence is not very high. So let's see if we can figure this out. How does low prevalence affect A, B, C, and D? And what does that have to do with relative risk calculation? If disease prevalence is low, you're going to decrease A and C and you'll increase B and D. Let's assume that the disease prevalence is so low that A and C become minuscule. If A and C become minuscule, how does the equation for relative risk change? Remember, the equation for relative risk was A over A plus B divided by C over C plus D. So if A is a tiny number relative to B, then A plus B essentially just becomes B, right? If A is 1 and B is 1,000, there's not much difference between 1 over 1,000 and 1 over 1,001. So when prevalence is low, A over A plus B essentially becomes A over B. And when C is minuscule, C over C plus D becomes C over D. So when prevalence is very low, the relative risk equation becomes A over B divided by C over D. And then look back at the equation for odds ratio. It's the same thing, A over B divided by C over D. So if you have the equation for relative risk memorized and you know that odds ratio approximates relative risk when prevalence is low, then you should know the equation for odds ratio too. Now let's talk about attributable risk, which is slightly different. Attributable risk is the difference between the risk of disease among the exposed and the risk of the disease among the non-exposed. So this implies that there is a risk factor that is increasing the risk of disease. There's an example for you in your study guide. It says that attributable risk is the incidence of disease in the exposed group minus the incidence of disease in the unexposed group. For example, in a group of sexually active people, 30% have HPV infection. In a population of people who are not sexually active, only 5% have HPV infection. Therefore, the attributable risk of sexual activity to HPV is 25%. This is an example of how you would have to calculate attributable risk on step 1. It's not difficult as long as you know the concepts and remember the equations. Now, let's take a second to talk about absolute risk reduction. The absolute risk reduction equation looks a lot like the equation for attributable risk, but instead of looking at how much a risk factor increases the risk of disease, we're looking at how much a beneficial intervention will decrease the risk of disease. In other words, A over A plus B becomes the proportion of people who have the disease from amongst all the people who receive the intervention, like a study drug. C over C plus D becomes the proportion of people with disease out of the entire population that did not receive the intervention of the study drug. So the calculation for absolute risk reduction is C over C plus D minus A over A plus B. We want to know the difference between the risk of disease in the control group and the risk of disease in the experimental group. If the risk of disease without the drug is 10%, but with the drug is 5%, then the absolute risk reduction is 5%. Now let's go back to the study guide to discuss number needed to treat. The number needed to treat, or NNT, is 1 divided by the absolute risk reduction. If you can calculate the absolute risk reduction, you can calculate the number needed to treat. The number needed to treat is the number of patients you would need to treat in order to save one life or to avoid one bad outcome. It's the number of people you would need to treat to get the effect that you want to get in at least one person. This can be an important number to help determine if a drug is cost effective. If you have a drug out there that has a very small effect and you need to treat thousands of patients in order to affect one life, the drug probably isn't worthy of widespread use. We also use this number to evaluate clinical effectiveness of a drug. There's an example in your study guide. There are 100 acute stroke patients given TPA, which is a clot-busting drug, and 40 of them have complete or near complete recovery. There are 400 acute stroke patients not given TPA, and 80 of them have complete or near complete recovery. First, you calculate the absolute risk reduction, which is the risk of poor outcome without the treatment minus the risk of poor outcome with the treatment. Poor outcome was experienced in 320 out of the 400 in the control group who were not given TPA, which is C over C plus D. And poor outcome was experienced in 60 out of the 100 in the group given the TPA, which is A over A plus B. So the absolute risk reduction is 320 divided by 400 minus 60 divided by 100, which is 0.2. To calculate number needed to treat, you would take the inverse of the absolute risk reduction. That is, you calculate 1 over the absolute risk reduction, which is 1 divided by 0.2, and this equals 5. Therefore, you would need to treat 5 patients with acute stroke to see the beneficial effect of TPA in one patient. There's also a similar concept called the number needed to harm, which I'll just mention briefly. Like I said, attributable risk is similar to the absolute risk reduction. It's just a measurement of the extra risk that's due to an exposure rather than the decrease in risk that's due to some beneficial intervention. So as you might expect, number needed to harm is similar to the number needed to treat. The number needed to harm is 1 divided by the attributable risk. Go ahead and look at your study guide again. What's the absolute risk reduction and number needed to treat in the following example? In a study where 100 patients received medication Z to prevent the development of diabetes and 200 patients did not receive the medication, 10 patients in the experimental group developed diabetes and 40 patients in the control group developed diabetes. I want you to pause the video and try to work that out. Don't take more than 1 or 2 minutes. And then we'll go back over it together. So the first thing to do is to set up a 2x2 table. A is 10 because 10 people received drug Z but still got diabetes. We know that A plus B is 100 because that's the total number of subjects that were given the drug. So if A plus B is 100 and A is 10, then B's got to be 90. C is 40 because this was the number of people in the control group who developed diabetes. And then if the total number of subjects in the control group is 200, then D has got to be 160. So the equation C over C plus D minus A over A plus B comes out to 40 over 200 minus 10 over 100, or 0.2 minus 0.1. So the absolute risk reduction with the study drug is 0.1, or 10%. Then what is the number needed to treat? Remember, the number needed to treat is 1 over the absolute risk reduction. Therefore, the number needed to treat in this question is 1 divided by 0.1, which is 10. Therefore, you would need to treat 10 patients to prevent 1 case of diabetes. All right. This is all high-yield stuff. Odds ratio, relative risk, attributable risk, absolute risk reduction, number needed to treat, and number needed to harm are all 5-star topics. Now, we're briefly going to cover precision and accuracy, also known as reliability and validity. So precision, or reliability, is a measure of how reproducible a result is. With a precise or reliable test, you get consistent results every time. So a precise test will not have random variation and will therefore be reliable and reproducible. But the kicker is that precision does not necessarily imply that the reliable and reproducible results actually reflect the truth. That's where accuracy comes in. Accuracy or validity is a description of how closely the test results reflect the truth. With an accurate test, there may be variation in the results, but the variation will occur right around the true value. So you should remember the difference between reliability and validity. Validity is how accurate a test is, or how well it reflects the truth. And reliability is how reproducible the test is. Ideally, any test you would use would have a combination of precision and accuracy. All right, that's all we're going to cover for this video. So what I want you to do now is pause the video, answer those end of session quiz questions in your study guide, and then we'll go over those answers together. Okay, let's get started. First question. What are the equations for odds ratio, relative risk, attributable risk, and number needed to treat? Odds ratio is A over B divided by C over D. Or another way to say this is A times D divided by B times C. This is the odds of having a particular disease in a group with a risk factor divided by the odds of having a particular disease without the risk factor. Relative risk is A over A plus B divided by C over C plus D. This is the probability of acquiring a particular disease in a group with a risk factor or exposure compared to the group without the risk factor or exposure. Attributable risk is the risk of developing a disease in a group with the risk factor minus the risk in the group without the risk factor, or A over A plus B minus C over C plus D. And then number needed to treat is just 1 divided by the absolute risk reduction. And just like the last video, there's no rapid fire facts, but make sure you know these equations because these would be our rapid fire facts. And also know the absolute risk reduction. Okay, next. The small town of Mickey City, population 8,000, is immediately adjacent to factories where asbestos products are produced. During the past year, the prevalence of mesothelioma has been 16 cases. In the town of Donaldville, population 6,000, 15 miles upwind, and theoretically a safe distance from Mickey City, there was a prevalence of 3 cases during the same year. What is the relative risk of mesothelioma in the population of Mickey City? So the first thing that you're going to do is set up your table, just like this. The number of people with the disease in Mickey City is 16. And the number of people with the disease in Donaldville is 3. The question didn't give you the number of people without the disease, but you don't really need it. All you need to know here is A plus B and C plus D, since the equation for relative risk is A over A plus B divided by C over C plus D. So 16 over 8,000 divided by 3 over 6,000, and that gives you 4. So the relative risk is 4. This risk of mesothelioma is 4 times higher in Mickey City than it is in Donaldville. Next, a new glucose test arrives and you decide to see how well it works. There's a standard substance provided that has 90 milligrams per deciliter of glucose. Your repeated measurements of the substance reveal the following values: 54, 56, 55, 54, 53, 56, 55, and 54. What can you say about the precision and accuracy of your new glucose test? Well, you would say that this test is very precise, since the results are staying within a very narrow range of numbers. The results are very reproducible, but the test is not accurate. The results aren't anywhere close to the true value, which would be 90. And last question, the prevalence of disease X in population A is 2 times the prevalence of disease X in population B. The incidence is the same in populations A and B. So what can be assumed about the disease duration in population A versus population B? Well, if the incidence is the same in both populations, but the prevalence is different, then you have to assume that disease lasts longer in one population versus the other. So in this example, the duration of disease X is twice as long in population A as in population B. And that's the end of our end of session quiz, and that's the end of our lecture on application of test data. I'll see you next time.